Thank you, Professor Hussein. So my talk today is about potassium disorders in hemodialysis. So potassium is a very important cation. It plays an important role in integrity of protein and muscles, resting membrane potential, and acid-base and osmotic balance. As we all know, potassium is mainly intracellular, in contrast to sodium, which is the main extracellular cation. So most of potassium is present inside cells, while only about 2% is present extracellular. We receive about 100 milliequivalent of potassium in diet daily, and we excrete nearly a similar amount of potassium, mainly in the urine. That's why when we have kidney disease, there will be impairment of potassium excretion and hyperkalemia. So my talk today is about dyskalemia in hemodialysis. So it might include hyper or hypokalemia. So what about prevalence of dyskalemia in hemodialysis? As we all expect, hyperkalemia is more common in hemodialysis patients, while hypokalemia is more common in peritoneal dialysis patients. Therefore, about 5 to 10% of hemodialysis patients will have potassium more than 6, in contrast to only 0.5% of peritoneal dialysis patients. On the other hand, up to 1/3 of peritoneal dialysis patients will have hypokalemia. Whether hyper or hypokalemia is a very important issue in hemodialysis, and it is a common cause of death among hemodialysis patients. So we have causes of dyskalemia related to hemodialysis, and we have other common causes of dyskalemia like any other person. So inefficient dialysis will cause hyperkalemia, while overdialysis will cause hypokalemia. Patients with residual function, especially those who are starting dialysis, are more exposed to hypokalemia on dialysis. Acidosis will cause hyperkalemia, while alkalosis will cause hypokalemia. It's very important for both physician and patient to know about foods which contain high and low potassium. So, for example, cantaloupe, dates, and avocado are very rich in potassium compared to pear, apple, and plums. Tomato juice is very rich in potassium. Also tomato, potato, sweet potato, lentils, and dried beans. Fresh vegetables also contain potassium, but less than dried vegetables. Rice, noodles, and pasta contain little bit lower potassium level compared to chocolate and milk. Cakes, pies without chocolate, little amount of coffee or tea contain a little bit low potassium compared to nuts and broth and yogurt. So it is very important to know in general which fruits are rich in potassium and which are poor in potassium, but more importantly to emphasize that the amount which is served is very important. For example, if we know that avocado is very rich in potassium, while plum is low in potassium, yet eating much amount of plum or apple might end with higher potassium intake than a little bit or a little portion of avocado. What are other causes of dyskalemia which might or might not be related to hemodialysis itself? What about glucose? Does it increase or decrease potassium? Well, we all know that one of treatment of hyperkalemia is to give glucose. But this will cause hypokalemia if insulin is there. Whether it is external insulin or internal insulin to make glucose enter inside the cell. However, the case is different if we have hyperglycemia due to uncontrolled diabetes. Here, lack of insulin and increase in osmolarity will cause hyperkalemia. So, if glucose is associated with insulin, whether external or internal, which will move glucose inside the cell, that will cause hypokalemia. However, if insulin is lacking, this will cause hyperkalemia. Take care about what's called rebound hyperkalemia after dialysis. So it's not good to check for potassium immediately after dialysis because this might be fake of hypokalemia. On the other hand, if we wait for 1 or 2 hours, then will be what's called rebound hyperkalemia. GIT losses are common cause of hypokalemia even on hemodialysis. That's why if my hemodialysis patient comes with severe gastrointestinal loss, then this must be considered. So if he is on normal potassium bath, for example, this must be shifted to high potassium bath and potassium must be checked. Muscle breakdown will cause hyperkalemia like cases of rhabdo. What about drugs? I think we all know that potassium-sparing diuretics will cause hyperkalemia, while potassium-losing diuretics in patients who still have residual kidney function will cause hypokalemia. Beta stimulants are used as inhalation to decrease potassium, while beta blockers might be a cause of hyperkalemia. Low molecular weight might cause hyperkalemia, while burden of abuse will cause GIT losses and hypokalemia. While hypokalemia might be a cause of digitalis toxicity, yet digitalis overdose might cause hyperkalemia. Trimethoprim sulfur methoxazole on dialysis might cause more hyperkalemia. ACE and ARBs, very common cause of hyperkalemia, especially on dialysis. Non-steroidal anti-inflammatory, cyclosporin and tacrolimus. Other causes of dyskalemia, which might or might not be related to hemodialysis, are hemolysis, which might occur independent of dialysis or be due to intradialytic hemolysis, blood transfusion, especially old blood transfusion, and post-parathyroidectomy. We have to take care of what's called pseudo-dyskalemia, pseudo-hyper or pseudo-hypokalemia. So, prolonged storage of the sample might cause either hypo or hyperkalemia, which is fake. Warming will cause pseudo-hypokalemia, while cooling of the sample might cause pseudo-hyperkalemia. Tourniquet and narrow-bore needle will cause hemolysis of RBCs in the sample and will cause pseudo-hyperkalemia. And importantly, very high white BCs and platelets might cause pseudo-hyperkalemia. What about manifestations of hyper and hypokalemia? In fact, regarding manifestations, both are nearly similar. So, both can be asymptomatic. Both can affect muscle with muscle weakness and paralysis, hypokalemia specifically might cause ileus, respiratory failure, and rhabdomyolysis. Both can affect cardiovascular system with palpitation, arrhythmias. Hypokalemia will increase digitalis toxicity and might end with arrest. However, ECG findings are nearly the reverse. While both might show bradycardia, VTAC, and arrest, yet classic signs of hyperkalemia in ECG include what's called PEAT or tall T wave, followed by loss of P wave, and then widening of QRS complex. And this pre-stages serious arrhythmias and might end by what's called sine wave or sinusoidal pattern. Tall peaked wave, while considered by many nephrologists, is unfortunately non-specific and is usually a marker of acute hyperkalemia. However, in hemodialysis, it might not occur except if potassium exceeds 6.5. So, progression and severity of ECG changes do not correlate well with serum potassium, and serum potassium should be the major and the main guide to monitor therapy. However, this is not against the importance of ECG. I mean, ECG changes are very important, but if ECG are not present, still potassium might be very high and must be checked. ECG findings in hypokalemia will include nearly the reverse, with flattening of T wave, peaked P wave, and appearance of U wave, and long PR and QT intervals. The ideal pre-dialysis potassium is not well settled. However, it is said that 5 to 5.5 millimole per liter pre-dialysis has the lowest mortality risk. So, hemodialysis patients with higher level or lower levels might have lower mortality, and it is like U-shaped curve. So if potassium is above 6.5, this is associated with higher mortality, and so if potassium before dialysis is below 4. How can we prevent dyskalemia in hemodialysis? First, we need counseling, low potassium diet, and we should educate our patients that almost all foods have some potassium, and it is important to consider size even rather than the type of food itself. Eat a variety of foods, but in moderation, and for green vegetables to be cooked. Boiling and leaching decreases potassium. Efficient dialysis is very important. Correction of other causes that might lead to hyperkalemia, like acidosis, drugs. And if loop diuretic is indicated, this might help to prevent potassium. What about dialysate potassium? The usual level is 2 millimole per liter, what's called normal potassium bath. So it is low for the body, but for dialysis it's called normal bath, commonly called like normal bath, because this is the standard potassium level in dialysate. So the tradition was to consider using less potassium in dialysate, like what's called low potassium bath and potassium-free dialysate. So that if potassium is higher than 5.5, some authorities might use lower potassium dialysis, like what's called low potassium bath or even potassium-free bath. However, there is a link between low potassium bath dialysate on chronic basis and increased incidence of cardiac arrest. That's why the safest level is 2, which is normal bath. And if pre-dialysis potassium is below 4, then use what's called high potassium bath, which ranges from 3 to 4. In my country here, we only use normal potassium bath, which contain 2 millimole per liter. If my patient on hemodialysis has chronic hyperkalemia, intensification of dialysis is very important, efficient dialysis is very important. But what about chronic use of what's called cation exchange rhythm? In fact, this is a debatable issue to use it on chronic basis. So one policy is to use calcium polystyrene sulfonate rhythm, which chelates potassium in gut. And for every gram of calcium resonium, this will remove 1 millimole per liter from gut. But of course, liters in gut are not all liters in the body, so it will decrease potassium. Perhaps the most commonly used cation exchange resin, and the oldest one, is what's called SPS, sodium polystyrene sulfonate. But this cation exchange resin might be associated with a number of side effects, including hypernatremia, hypocalcemia, electrolyte disturbances, and very importantly, intestinal necrosis. So while it was used for a long time with sorbitol to decrease constipation, there was warning books in 2009 not to use it with sorbitol. So it might be safer to use calcium-based cation exchange resin if we are going to use cation exchange resin. Licorice is a very common drink in my country here, and some studies show that licorice might be an alternative to prevent hyperkalemia in dialysis patients by working like aldosterone causing hyperkalemia. What about treatment of dyskalemia? In fact, the only 2 modules to treat hyperkalemia, which work immediately, is IV calcium to protect heart and hemodialysis. Other strategies might be prolonged up to hours, like sodium bicarbonate and oral cation exchange resin. First, I have to ask myself, is it true or fake hyperkalemia? Second, I have to ask myself, how severe is hyperkalemia? So, if potassium is 7, or if ECG or symptoms appear at any level of potassium above 5.5, this is considered severe hyperkalemia. However, we have to consider that mild hyperkalemia is common and often well tolerated in patients with chronic renal failure. So it is not uncommon to see my dialysis patients coming with potassium like 5.5 and 6 and 6.2 without any symptoms. So here this should be considered. Hyperkalemia on chronic basis in hemodialysis patients is completely different than hyperkalemia acute in CCU, so both are completely different. So urgency is important. So if potassium is above 7, or if it is associated with ECG changes or symptoms, this is urgent for treatment. So, which treatment should I do? First, as we all know, we have to protect heart. By giving IV calcium gluconate. And here is an important issue. Calcium gluconate is not given necessarily for peaked T wave. So, if I have peak T wave, this does not mandate IV calcium. However, if I have loss of P or wide QRS complex, this mandates IV calcium. And we have to be even more conservative in dialysis patients to give IV calcium because of side effects we all know about giving IV calcium, like metastatic calcification. So we have to be more conservative in our hemodialysis patients about IV calcium. Second, I have to remove potassium from the body. And the most efficient way to correct hyperkalemia in hemodialysis patient is simply to do a session of hemodialysis. Take care of rebound, which occurs 1 or 2 hours after hemodialysis, especially if pre-hemodialysis potassium is high or if sodium is high in dialysate. And if you give some anti-hyperkalemic measures, this is unfortunately might increase rebound of potassium. Again, which bath should I use? Again, the commonest bath is to use what's called normal bath, which is 2 millimole per liter. If potassium before dialysis is below 4, please use high potassium dialysate. And if potassium is higher than 5.5, still normal bath is very efficient, and we might not need to use low potassium dialysate of 1 or 1.5, except if potassium is above 8 and on acute basis. So normal potassium bath is the best and the most. Still, we can use the gut by cation exchange resins, I have just talked about them, to treat hyperkalemia, and here dose is higher than prevention dose. But unfortunately, onset of action is slow. And again, SPS, sodium polystyrene sulfonate, was the first one to be approved in 1950s. But in 2009, there was a black box to use it with sorbitol because this will increase intestinal necrosis. A rare complication, but a very serious complication. And don't use enemas if the patient has recent abdominal surgery. 2, cation exchange resins in phase 3 studies. One is awaiting FDA approval and the other has just been approved by FDA. One is sodium zirconium cyclosilicate, ZS9. And this is non-absorbable inorganic monovalent cation which has high affinity to potassium, entrapping it in the gut. And unlike sodium kxalate, it doesn't swell in the gut. And here is a study from JAMA 1.5 years ago, harmonized study, proving its efficacy in acute and little bit long-term treatment of hyperkalemia. Another study, phase 3, more than 700 patients. And they are awaiting. ZS Pharma, just purchased by AstraZeneca, is waiting for FDA approval in the next few months. another cation exchange resin, Potassium. Heteromere, again, it doesn't swell in the gut. Still in phase 3, the common side effect of zirconium is edema, while the most common side effect of the new Veltasa is GIT disturbances and hypomagnesemia. Again, very prestigious publication proving its efficacy in hyperkalemia, FDA approved. However, both new agents are waiting for more studies to prove their efficacy in long-term patients and to compare them to the conventional cation exchange resins. Loop diuretic can be used if the patient has residual kidney function to treat hyperkalemia, and after protecting heart and removal of potassium from body, there is also room, although temporary, to shift the potassium from blood to cell by giving glucose insulin. Take care of this dose of insulin because this might cause hypoglycemia, so you might modulate this dose to 5 units, or even you can give glucose without insulin. Still, it will work if intrinsic insulin is present. Most of the traditional ways to treat hyperkalemia in hemodialysis patients, other than hemodialysis, are unfortunately ineffective in hemodialysis patients. So, salbutamol beta-stimulant inhalation, which is efficient in normal population, might not work in all patients, and especially in dialysis patients, whom 40% of them might be resistant to inhaled beta-stimulants. Therefore, salbutamol is not recommended as single agent to treat hyperkalemia in hemodialysis patients. Again, the most efficient treatment is to dialyze the patient. Sodium bicarbonate, which is part of treatment of hyperkalemia in non-hemodialysis patients, is not recommended again in hemodialysis patients, except if there is metabolic acidosis. It is also non-effective to give sodium bicarbonate in hemodialysis patients as antihyperkalemic agents. So, what about hyperkalemia in patients who are going to do surgery? This will depend on clinical situation, urgency of surgery. So, if potassium is around 6 in hemodialysis patient, ECG changes, and surgery is urgent, go for surgery. Otherwise, dialyze safely first, or medical treatment if you cannot do dialysis. So, although hypokalemia is a little bit less common in hemodialysis patients, then it is still present in hemodialysis patients, especially if there is GIT losses, residual kidney function, or other causes of hypokalemia. And please don't use IV potassium chloride except if oral supplementation cannot be used. So, diet is very important. Increase potassium in diet. Avoid alkalosis, which will be associated with hyperkalemia. We might use potassium-sparing diuretics, but this must be very closely monitored and at a maximum dose of 25 milligrams spironolactone per day. Here is very important to increase potassium in dialysate, and this is very important and efficient treatment to increase potassium to 3.5 or 4 if pre-dialysis potassium is 4 or below 4. Always, you will be skeptical about giving hemodialysis patient potassium-sparing diuretic and potassium supplementation, even if it is orally. So, the most important treatment is to review diet, review alkalosis, and do high potassium dialysis. So indication for urgent replacement of hypokalemia will include electrocardiographic abnormalities or the presence of myocardial infarction, hypoxia, digitalis intoxication, or severe musculoskeletal symptoms. And please note that because potassium is intracellular, so only minor change in serum potassium reflecting a great change in total body potassium. So only 0.25 millimole per liter decrease means that we have 100 millimole deficit. So if potassium is below 3, this means that potassium deficit is about 300 or more. And if it is below 2, this means that deficit is too much, that it might exceed 700. Again, IV potassium is usually not needed. Here in my country, we might use it intradialytic because we don't have alternative for high potassium bath. So we use normal bath too and give some intradialytic IV potassium. However, don't forget that maximum rate of infusion is 10 millimole per hour. So, for oral potassium, every 50 millimole increases serum potassium by about 1 millimole per liter. And these are examples of oral potassium supplementation. However, please rely on diet, correction of alkalosis if present, and high potassium during dialysis. So take home message, dyskalemia is not uncommon in hemodialysis patients, and this is a very important cause of death among hemodialysis patients, whether hyper or hyperkalemia. And the treatment of potassium increase in dialysis patients is different than other people. Hyperkalemia is not responding well to usual measures like nebulizers, like sodium bicarbonate, and we usually don't need IV calcium with hemodialysis patients. Dialysis patients, this is the safest way to treat. Thank you very much.
Thank you very much, Professor Donia, for this excellent, illustrative and comprehensive overview about dyskalemia in dialysis. And I'm going to have questions. Yes? Questions? Yes, please.
I noticed that you mentioned glycogen as one way to reduce hyperkalemia. Now I was wondering, like,